Let's talk about something you're going to see all the time in gynecology, cervical erosion. But here's the thing, that name is completely misleading. It's a term that trips up a lot of students, so today we're going to clear up this super high-yield topic so you know exactly what it is, why it happens, and what to do about it. Let's dive in.
So let's start with this really important question. The word erosion makes you think of tissue getting worn away, right? Like an ulcer. But what if that's not what's happening at all? Getting this one simple idea right is the key to understanding this entire concept.
So, here's our game plan. We'll start by fixing that misleading name. Then we'll get into the key anatomy and the hormones behind it. After that, we'll look at how it shows up in the clinic, how it heals, and, really importantly, how to tell it apart from its mimics. And we'll wrap up with the key takeaways for your exams.
All right, first things first, we have to get the terminology right. Ditching the word erosion is step one to actually understanding the physiology here.
The correct term, the one you need to use, is cervical ectopy. And as you can see, this is not about tissue loss. It's simply a replacement. The tough, protective squamous cells on the outside of the cervix get replaced by the softer, mucus-producing columnar cells from the inside. So think of it as a change in the cell type, not a wound or an ulcer.
Now, to really get how this replacement happens, we need to zoom in on one critical anatomical landmark. Honestly, this spot is the key to the whole story.
Okay, take a look at this diagram. It shows you everything. On the top, you see the normal setup. That line where the pale pink outer cells meet the reddish inner cells, that's the squamocolumnar junction, or the SCJ. Now, look at the bottom image. See what's happened? That junction, that line, has moved outwards. The red glandular columnar cells are now visible on the outside. That's cervical ectopy. It's that simple.
So, what's making that junction move? What's the driving force here? Well, it all comes down to hormones. Now, ectopy can be congenital. You see it in newborns because of their mother's estrogen, but that usually just goes away on its own. For us, what's clinically important is the acquired hormonal cause. And here's the big concept. The squamocolumnar junction is not a fixed static line. It's dynamic and it moves around in response to estrogen levels. And this is the golden rule you absolutely have to remember. High estrogen makes the squamocolumnar junction move outwards, which creates an ectopy. It's that direct. This is precisely why cervical ectopy is so common during pregnancy and in women who are on combined oral contraceptive pills. Both are classic high estrogen states.
Now, this averted tissue can look a few different ways. As you can see here, it might just be a simple flat red area. But if the tissue grows a lot, if it becomes hyperplastic, it can start to fold in on itself, which we call a follicular ectopy. Or if it folds in multiple directions, it can look kind of heaped up, and that's a papillary ectopy.
Okay, so we know what it is and why it happens. Now, how does a patient with ectopy actually present? And how does the body fix it?
You know, most of the time it's completely asymptomatic. The patient has no idea it's there. But if they do have symptoms, it makes perfect sense. They might get a lot of mucoid discharge because columnar cells make mucus. Or they might get some contact bleeding because that single layer of cells is just more delicate. On examination, you'll see a bright red patch. It feels soft and kind of granular. But, and this is a really important point to differentiate it from cancer, it does not bleed easily when you gently touch it.
The body is pretty amazing. It usually heals this all by itself in a process we call epidermidization. Basically, the squamous cells just start to grow back over the area. This can happen either by them creeping underneath the columnar cells or through a cool process of cell transformation called squamous metaplasia. As this happens, that junction moves back inwards. Now, a neat little side effect here. If one of the mucus gland openings gets covered up by this new layer of cells, the mucus gets trapped and forms a tiny retention cyst. That's what an epithelial follicle is.
All right, let's move on to a really high-yield section for your exams, telling cervical ectopy apart from other things that can look kind of similar.
A classic point of confusion is ectopy versus ectropion. They sound alike, but they're completely different. Ectopy is a physiological change in the cell type because of hormones. Ectropion, on the other hand, is purely mechanical. Think of it like the cuff of a sleeve being turned inside out. It's usually because of an old tear from childbirth that physically pulls the lips of the cervix open, exposing the inside canal.
Now, this is the most critical one, telling ectopy apart from an early carcinoma. Just remember, ectopy is soft and doesn't bleed easily. The red flags for cancer are the exact opposite. The lesion might feel hard or indurated. It'll be friable, meaning it's fragile and bleeds with just a gentle touch.
and you might see a real ulcer. If you see any of those red flags, you have to be suspicious, and you need a smear and a biopsy to confirm.
All right, let's pull all of this together. We're going to summarize the most important high-yield points that you absolutely have to know.
Let's recap. First, erosion is the wrong word. Ectopy is a replacement of cells. Second, it's a normal process driven by high estrogen. Third, remember the squamo-columnar junction is dynamic, it's not static. Fourth, it heals on its own through epidermidization, and this can create Nabothean cysts. And finally, you have to know how to differentiate it from ectropion, which is mechanical, and carcinoma, which is hard and bleeds easily.
If you only remember one thing from this whole explainer, let it be this. Cervical ectopy is a physiological shift of the SCJ, not a pathological erosion.
And we'll finish with one last clinical thought for you. Knowing all this, what is the single most important first step when you see any visible lesion on the cervix? The answer is you have to definitively rule out anything dangerous. And that means you start with cervical smear. Always, always confirm.